I want to tell you about a nurse I know who was struggling, genuinely struggling, not in the vague I am a little tired way, in the I do not want to go to work. I feel nothing when I should feel something. I am counting the hours until I can leave a job I used to love kind of way. And everyone around her kept telling her the same thing. Take care of yourself. Practice self-care. Journal. Try yoga. Set better boundaries. Use your PTO. She was given pamphlets. She was given the number for the EAP. She was sent links to mindfulness apps. Her manager mentioned resilience in a staff meeting, and she tried all of it. The journaling, the yoga class she went to twice, the boundaries she tried to set with a staffing ratio that made boundaries structurally impossible. None of it worked. And here's the part that broke her in a different way. The fact that it did not work made her feel worse, because now the message she was receiving was not just that she was struggling. It was that she was struggling and she was doing something wrong because the things that were supposed to help were not helping. She was not broken. She was burned out. And burnout is not a self-care problem. Burnout is not a resilience deficit. Burnout is not fixed by yoga. Here is what nobody told her and what I want to tell you today. Burnout and compassion fatigue are two distinct conditions with two distinct mechanisms and two distinct sets of evidence-based interventions. And if you apply the intervention for one to the other, it will not work. Not because you are not trying hard enough, because you have the wrong diagnosis. The healthcare industry has been conflating these two conditions for decades, sometimes because of genuine conceptual confusion, sometimes because addressing compassion fatigue with wellness resources is cheaper and more organizationally convenient than addressing burnout by fixing the systems that produce it. And nurses are paying the price for that conflation with their careers and their well-being. Hippocrates built rest, recovery, and the well-being of the healer into his clinical philosophy. He knew that a sick physician is a dangerous physician. 25 centuries later, we are still struggling to apply that principle to our own profession. Today, we are going to get the diagnosis right. Welcome to Think Like a Provider. Let's get into it. I'm Professor Jenna Way, nurse practitioner, clinical educator, and creator of Think Like a Provider, the clinical reasoning system that teaches nurses and nursing students to master body systems through pathophysiology and evidence-based frameworks. We don't memorize here. We understand. If you're new, every episode, we break down the mechanisms behind clinical reasoning, neuroscience, and what it actually takes to perform at your best, so you walk away thinking and acting like the provider you are meant to be. And if you want to go deeper than a podcast can take you, we have clinical reasoning tools, ebooks, and a growing Facebook community where we break things down. And if you are ready for the full Academy experience, the Think Like a Provider Academy waitlist is open now. All the links are in the show notes. The greatest clinicians in history reasoned their way to the answer. So will you. Let's get into it. This is our wellness episode for the month, and I want to be very clear about what wellness means in the Think Like a Provider context before we go any further. This is not a self-care episode. This is a diagnostic episode. We are going to apply the same clinical reasoning framework we use for patients to ourselves. Starting with getting the right diagnosis before we talk about any intervention, because the wrong intervention for the right condition is not neutral. It is harmful, and in this case, it has been harmful to an entire generation of nurses. Let's discuss the problem with conflating them. Let me start with why this distinction matters so much, not just for your personal well-being, but for the clinical reasoning framework that this entire podcast is built on. When a patient presents with chest pain, you do not assume the diagnosis and start treatment. You build a differential. You identify the mechanism. You choose the intervention that targets the specific mechanism producing the presentation. Because the same symptom, chest pain, can be produced by completely different mechanisms, such as ischemia, inflammation, spasm, structural problem, and referred pain. And the treatment for each is different, sometimes opposite. Giving a patient with aortic dissection the same treatment as a patient with GERD will not just fail, it will kill them. The same logic applies here. Burnout and compassion fatigue share overlapping symptoms: exhaustion, reduced effectiveness at work, emotional changes, difficulty sustaining motivation. If you see those symptoms and immediately apply a generic wellness intervention without identifying which condition is producing them, you are treating a symptom without a diagnosis. You may get lucky, more often you will not. And here is the research to support that concern. A 2022 study published in the Journal of Nursing Scholarship examining compassion fatigue, compassion satisfaction, and burnout in nurses across a large Texas healthcare system found that burnout and compassion fatigue, while related, are conceptually and operationally distinct, and that interventions targeting one may not adequately address the other. The study found that nurses experience both conditions simultaneously and at varying levels, underscoring the importance of assessing for each separately rather than assuming a single construct explains the whole presentation. A 2023 study published in the Journal of Research in Nursing found that empathy plays a mediating role in the relationship between compassion fatigue and burnout, meaning the two conditions interact with each other through a specific psychological mechanism, but that the original source and the maintenance of each condition differ. Compassion fatigue affects burnout through its impact on empathy. Burnout does not necessarily affect compassion fatigue through the same pathway. They are related, they are not the same. So let us define them properly, not with textbook language, with mechanisms. What burnout actually is. Burnout was first systematically described by Christina Maslach in the 1970s, and the Maslach model remains the most widely used and most research-validated framework for understanding it. Burnout has three components: emotional exhaustion, depersonalization, and reduced sense of personal accomplishment. But the mechanism is what matters. And the mechanism of burnout is chronic occupational stress in the absence of adequate recovery, operating within an organizational context that does not provide sufficient autonomy, recognition, workload, manageability, fairness, community, or alignment with values. Listen to that again. Burnout is produced by the interaction between the person and the system they work within. It is not a personal failure of resilience. It is not a character flaw. It is the predictable biological and psychological outcome of sustained exposure to occupational demands that exceed available resources, when the system does not provide what the person needs to function sustainably. At the neurobiological level, burnout involves prolonged activation of the HPA axis, the hypothalamic pituitary adrenal axis, which is your primary stress response system. Chronic HPA axis activation produces sustained elevated cortisol. We have talked about cortisol throughout this podcast. In episode 8, in the context of nutrition. In episode 11, in the context of the amygdala hijack. In episode 12, in the context of sleep disruption. Chronic cortisol elevation does damage. It reduces hippocampal volume over time. Your hippocampus is your primary memory encoding structure, and cortisol is toxic to hippocampal neurons at sustained levels. It suppresses prefrontal cortex function, the very cognitive architecture you need for clinical reasoning, and it dysregulates the amygdala, increasing threat sensitivity and reducing the emotional regulation that allows you to stay calm under clinical pressure. This is why burnout is a patient safety issue and not just a personal wellness issue. A burned out nurse has measurably reduced working memory capacity, slower cognitive processing, reduced attention and vigilance, and impaired judgment. She is functioning with a neurologically compromised clinical reasoning apparatus, and she is doing so while responsible for patients who need her at her best. The three phases of burnout look like this in practice. Emotional exhaustion feels like you have nothing left to give. You arrive at work already depleted. The emotional labor of patient care, which requires you to hold space for suffering, to maintain therapeutic presence, to manage your own reactions while being fully present with someone else's pain, feels impossible. Not because you stopped caring, because you are running on an emotional tank that has been empty for longer than you want to admit. Depersonalization, also called cynicism in more recent frameworks, feels like emotional distancing from patients, from colleagues, from the work itself. You start to feel detached. You use coping language that you are not proud of. You find yourself looking at patients as a collection of tasks rather than as people. This is not moral failure. It is a protective mechanism, the psyche creating distance from emotional pain when the emotional resources to process that pain have been exhausted. Reduced sense of personal accomplishment feels like nothing you do matters. The effort you put in does not translate into outcomes you can see or feel. You feel ineffective. You stop feeling like you are making a difference. You question why you went into this field. Now, and this is critical, the primary driver of burnout is the organizational system, not the individual. Staffing ratios, administrative burden, lack of autonomy in clinical decisions, workplace culture, leadership quality, pay equity, shift length. These are the variables that the research consistently identifies as the strongest predictors of burnout. Individual factors matter: personal resilience, social support, self-care practices. But they are secondary to the systemic variables, which means if someone is burned out because they are working 12-hour shifts in a chronically understaffed unit with a hostile charge nurse and 90 minutes of documentation per patient per shift, the appropriate intervention is not yoga. The appropriate intervention is systemic change. This is what the nurse we discussed in the beginning needed, not a mindfulness app, a different staffing ratio, or a different unit, or an organization willing to address the conditions producing her depletion. When none of that was offered and wellness resources were offered instead, the message, however unintentionally, was, the problem is you, and the solution is for you to cope better with conditions we are not willing to change. That is not healthcare. That is gaslighting with a wellness rebrand. What compassion fatigue actually is. Compassion fatigue is a different animal, and understanding how it differs from burnout is what allows you to identify which one you are dealing with and choose the right intervention. Compassion fatigue was first described by Joynson in 1992 and further developed by Figley, who defined it as the cost of caring, the emotional and psychological burden of being a witness to the suffering of others. Compassion fatigue is specific to empathic, caregiving work. You cannot develop compassion fatigue from a job that does not require you to engage emotionally with other people's pain. An accountant does not develop compassion fatigue. A nurse absolutely can. The mechanism of compassion fatigue is vicarious traumatization, the indirect transmission of traumatic stress from patient to caregiver through sustained empathic engagement. When you care for a patient who is dying, who is in pain, who has experienced trauma, who is frightened, your mirror neuron system activates. You do not just understand their experience intellectually, you feel an echo of it. This is what makes nurses effective at their jobs. The empathic resonance that allows you to be genuinely present with a patient in their most vulnerable moments. But that same resonance, over time, with repeated exposure to suffering without adequate processing, produces a cumulative emotional burden that the research calls compassion fatigue. At the neurobiological level, compassion fatigue involves a different pattern than burnout. Where burnout is primarily an HPA axis and cortisol story, compassion fatigue has a stronger amygdala component. Repeated exposure to emotionally charged patient situations, death, suffering, trauma, pediatric cases that break your heart, produces sensitization of the amygdala's threat and emotional response circuits. Over time, the threshold for emotional activation lowers. You become more reactive to patient suffering. Your emotional regulation capacity decreases under the weight of accumulated vicarious trauma. And the paradoxical outcome, the psychological protective mechanism, is emotional numbing, detachment. The very empathy that made you vulnerable to compassion fatigue starts to shut down to protect you from further pain. This is the cruelest feature of compassion fatigue and the one that produces the most shame in nurses who experience it. You went into nursing because you cared, deeply, genuinely, personally, and now you are experiencing something that feels like not caring anymore. And you cannot reconcile those two realities, so you conclude that something is wrong with you. Nothing is wrong with you. Your nervous system is doing exactly what nervous systems do when they are overwhelmed by sustained exposure to emotional content without adequate processing. The emotional numbing is protective. The reduced empathy is a symptom. And treating it as a moral failing rather than a physiological response is both inaccurate and cruel. The characteristics of compassion fatigue look like this: a sudden or relatively rapid onset. Unlike burnout, which builds gradually over months or years, compassion fatigue can develop quickly after exposure to a particularly traumatic patient event or a sustained period of high acuity, emotionally demanding care. Intrusive thoughts or images related to specific patients, the patient who died on your shift, the pediatric code that did not go well, the face of a patient whose pain you could not adequately manage. Emotional numbing or blunting, the feeling that you are going through the clinical motions without the emotional presence that used to characterize your nursing practice. Avoidance of certain patient types, clinical scenarios, or conversations that trigger the emotional residue of past exposures. And, critically, hypervigilance around patient outcomes, driven by fear of further traumatic exposure rather than by clinical reasoning. The 2023 study in BMC nursing, examining oncology nurses, one of the highest risk populations for compassion fatigue, found that compassion fatigue was significantly associated with witnessing patient death and suffering, particularly in the absence of adequate debriefing and peer support structures. The exposure was the driver, not the workload volume per se. That is the distinction from burnout. Compassion fatigue is about the emotional content of the work. Burnout is about the structural conditions of the work. And here is where they can coexist and compound each other. A nurse who is chronically understaffed, a burnout driver, is also seeing more patients in more acute states without adequate time to process those encounters, a compassion fatigue driver. The two conditions are not mutually exclusive. Many nurses have both, but the interventions for each are different, and getting the primary diagnosis right is what allows you to choose the one that will actually help. Getting the right diagnosis. Before any intervention, you need to accurately identify what you are dealing with. And the clinical reasoning framework we use in this podcast applies here exactly as it applies to patient care. Ask yourself the following questions, honestly. Where is the depletion coming from? If you can work in a different setting, a different unit, a different patient population, a different organization, and feel meaningfully different, the driver is likely organizational and systemic. That points toward burnout. If the emotional weight follows you regardless of setting, if specific patient interactions or specific clinical scenarios are the primary trigger, that points more toward compassion fatigue. What is the onset and trajectory? Did this develop slowly over months and years of increasing workload, decreasing autonomy, and accumulating disillusionment? That is the burnout trajectory. Did it come on more rapidly, possibly connected to a specific traumatic patient experience or a period of particularly emotionally demanding care? That is more characteristic of compassion fatigue. What does the emotional content look like? Burnout often presents as generalized exhaustion, cynicism, and disconnection from meaning. The emotion is depleted. There is not much of anything left. Compassion fatigue often presents with more acute emotional content. Intrusive thoughts, specific patient faces, the inability to shake particular clinical moments, and then the numbing that follows as protection from that acute emotional pain. Do the standard wellness interventions help at all? If yoga, adequate sleep, and meaningful leisure activities produce genuine restoration, even partial, you are likely dealing with burnout, and the restoration strategies are appropriate. If nothing touches it, if the depletion seems to regenerate regardless of rest, the mechanism may be compassion fatigue driven. And the missing component is not rest, but processing. The emotional content needs to be addressed, not just rested away. The ProQOL, Professional Quality of Life Scale, is a validated tool that measures both burnout and compassion fatigue simultaneously and gives you separate scores for each. It is freely available, takes approximately 10 minutes to complete, and can give you a clearer picture of which condition is more prominent in your current experience. I will link it in the show notes. The right interventions for each. Now that you have the diagnosis, here is what the research actually supports. For burnout, and I want to be absolutely clear about this, the primary evidence-based interventions are organizational and systemic, reducing workload to sustainable levels, increasing professional autonomy and decision-making authority, creating meaningful recognition and reward structures, addressing workplace culture and leadership quality, building genuine community among clinical teams, aligning organizational values with the values of the people doing the work. Individual level interventions, adequate sleep, physical activity, social connection, meaningful activities outside of work, nutrition, boundaries around work-home separation are supportive and important, but they are maintenance interventions, not curative ones in the presence of unaddressed systemic burnout drivers. You cannot yoga your way out of a chronically understaffed unit. You cannot meditate your way out of an organization that treats nurses as disposable. If you are in a burned out state and you have some ability to influence your environment, Advocate for yourself and your colleagues at the unit level. If the systemic conditions cannot change, the most evidence-supported individual decision for severe burnout is environmental change. A different unit, a different specialty, a different organization, or a different role that addresses the specific burnout drivers you have identified. For compassion fatigue. The evidence base centers on processing, not resting. The emotional content of vicarious traumatization does not resolve through time off alone. It resolves through deliberately engaging with the emotional residue of the traumatic exposures and integrating it, rather than suppressing or avoiding it. This looks like structured peer debriefing after traumatic patient events. Conversations with colleagues who shared the experience where it is explicitly named and processed. It looks like clinical supervision or formal debriefing structures within the organization. It looks like individual therapy with a provider who understands occupational trauma. Specifically, trauma-focused modalities that address the vicarious traumatization mechanism. It looks like intentional reflection practices on journaling, specifically oriented toward the patient encounters that have accumulated as emotional weight, not general wellness journaling. And it looks like actively cultivating compassion satisfaction, the positive emotional experience of effective caregiving, as a counterweight to the accumulated compassion fatigue. Compassion satisfaction and compassion fatigue are inversely related in the research. Strengthening one reduces the impact of the other. Boundaries matter for compassion fatigue. Not in the popular wellness sense of simply limiting what you will and will not do, but in the specific sense of developing a deliberate transition ritual between clinical work and personal life that signals to your nervous system that the emotional processing load of the clinical environment is being set down. That transition does not happen automatically. For nurses whose empathic engagement is high and whose clinical work is emotionally demanding, the amygdala does not receive a clear signal that the exposure has ended when the shift ends. The intrusive thoughts continue. Building a deliberate decompression ritual, whatever form that takes for you personally, is a neurobiological intervention. It creates the signal that the exposure is contained. Hippocrates wrote about the physician's obligation to their own health as a prerequisite for the healing relationship. He understood that a depleted healer is a compromised healer, not because clinicians are not strong enough or dedicated enough, but because the human capacity for sustained empathic engagement, complex clinical reasoning, and effective patient care has genuine biological limits that must be respected, not overridden. You are not a machine. Your capacity to care for others at the level your patients deserve is dependent on the state of the biological and emotional systems you bring to every clinical encounter. Burnout depletes those systems through chronic systemic overload. Compassion fatigue depletes them through accumulated vicarious trauma. Both are real, both are mechanisms, and both respond to specific targeted interventions when you first get the diagnosis right. The message of this episode is not that you need to take better care of yourself. The message is that you deserve an accurate assessment of what is actually depleting you before anyone prescribes an intervention. You are a clinical reasoner. Apply that reasoning to yourself with the same rigor you apply it to your patients. Get the diagnosis right. The intervention follows from the mechanism, every time. For this week's homework, I want you to complete the ProQOL scale if you have not done so recently. The link is in the show notes. Look at your separate scores for burnout and compassion fatigue. Notice which one is higher, and then bring that data to any conversation you have about your professional well-being. With yourself, with a supervisor, with a therapist, with a colleague. You deserve a diagnosis before you get a treatment plan. Every patient does, so do you. Clinical reasoning tools, ebooks, and our Facebook community are in the show notes. If you are navigating burnout or compassion fatigue and want to be in a community of nurses who understand what that actually feels like, come find us. Your well-being is not optional. It is clinical. I will see you next week.